تسلم وتعيش يا فندم. واحنا على يوتيوب اهو دلوقتي انا شايف.
ايوه بالضبط، بدأنا ستريمينج. الله يبارك فيك. اوكي، معانا لسه 5 دقائق معلش لغايه ما
تمام، لا
الناس.
مفيش اي مشكله، مفيش اي مشكله. مفيش اي مشكله اطلاقا. انا برضو بشوف اللينك بتاعت اليوتيوب بحيث ان انا ابعتها للزملاء.
كويس، حلو.
اشوفها ازاي يا دكتور مازن؟ على
اللينك.
يعني اللينك بتاع اليوتيوب الاقيها ازاي؟ على اليوتيوب نفسها؟
لا حضرتك، ما بعرف انا الشاشه اللي شايفها انت حضرتك، فوق يسار. شايف
في
شيء
اون
مكتوب لايف؟
يوتيوب شايفها.
ايوه،
شايفها. كوبي
اكبس
ستريمينج.
السهم.
تمام. تمام. فهمت يا فندم.
الحراره شلون عندكم؟ ايش
والله
بيصير؟
برد، بس مش برد قارس، يعني برد معقول الحقيقة. يعني مش محتمل جدا. ما
حلو.
اقدرش اقول ان انا. هو بص حضرتك، الموضوع غريب قوي في موضوع البرد ده، انه لسبب لا اعلمه. لما تنزل مصر في ديسمبر القاهرة بيبقى البرد قارس جدا، برغم ان درجات الحرارة مش واطية زي جنيف. يعني جنيف
مم.
3 2 0 حتى الواحد يقدر يعيش كويس قوي، لكن تلاقي في القاهرة 10 تبقى انت
مم.
حالتك صعبة جدا. طبعا جزء منها ان البيوت مش معزولة بالشكل اللي معزولة بيه في اوروبا. يعني اوروبا صيف شتاء انت محافظ على تقريبا نفس درجة الحرارة في البيت. لكن اعتقد ان الموضوع اكيد له دعوة بالهيوميديتي والجفاف، ومش عارف.
مم.
يعني مش قادر اقول لحضرتك ايه السبب، بس انا لما نزلت في ديسمبر القاهرة كان البرد مخيف، يعني الحقيقة أكتر من هنا بكتير. يعني الواحد بيلبس لايرز، حضرتك عارف طبعا، وخلاص وبتعدي يعني. واحنا ما احنا محبوسين في المكاتب وفي المستشفيات طول الوقت،
اه.
والمستشفيات معزولة كويس. هي المشكلة بقى لما الصيف بيبقى موجود في جنيف ودرجة الحرارة توصل مثلا 36 37 في مباني طوب ما فيهاش تكييف خالص، التكييف بس
مم.
هو في العمليات.
اه.
فده بيبقى صعب
صح.
الحقيقه. ده اصعب بكتير من البرد في اوروبا في رايي يعني.
صح.
يعني الحمد لله على كل شيء.
طبعا الحمد لله.
الحمد لله.
خالد الغزالي بيقول greetings everyone. اهلا وسهلا يا استاذ خالد.
دكتور خالد، انتوا تعرفوا بعض؟
لا.
دكتور خالد كونسلتنت جلوكوما في كاترينج في اليو كي.
ما شاء
واحد
الله.
من اكابر واعاظم الناس، واحد من اكتر الناس اللي انا بحبهم في حياتي كطبيب وكانسان
ما شاء
وكصديق
الله.
واخ اكبر يعني. فيعني انا سعيد جدا بوجود خالد معانا.
ما شاء الله. ما شاء الله، تشرفنا والله. انت الدكتور طارق اكيد يعني ما بتجيب لنا غير الناس الاكابر اللي زي حضرتك، اكيد يعني.
يا فندم ربنا يكرمك، ربنا يكرمك. هو يعني بس يعني ربنا يعني يجعل في كلامنا القبول، ويجزينا خيرا،
امين.
ويتقبل عملنا خالصا لوجه
امين.
الله. والله يعني ما
تسلم.
ليس فيه اي شيء اكثر من ان احنا
نعم.
يعني حبا في العلم وحبا في الناس اللي عايزين، او الواحد حضرتك عارف احنا بنتشارك في القليل الذي نعرفه، لان هو قليل فعلا. احنا لا نتشارك في معرفة كاملة للعلم، ده بالعكس، ده احنا الواحد كل يوم يكتشف قد ايه هو جاهل في، سواء في تخصصه او في غير تخصصه. يعني الحمد لله على كل شيء، او الواحد كلنا بنحاول.
نعم.
انا جاهز يا بك، shall we start ولا ايه رأيك؟
آه، هو لسه الناس بتعاني شويه من الدخول، فلو نصبر بس دقيقتين لو
حاضر
تكرم.
حاضر، عينيا تحت امر حضرتك.
الله يخليك، استغفر الله، الله يحفظك يا رب. هو لانه we created this link يعني very quickly، فبعد ما اجلنا الموضوع من السنه اللي فاتت لغايه دلوقتي، فلذلك يعني صار في شويه technical issues، خاصه انه we already booked the full 2022
سكادجول.
بلاتفورم. ايوه سكجول بالضبط. فده
تمام.
طلع له لينك مختلف عنهم، فلذلك
اه
يعني صار.
مفهوم، مفهوم، مفهوم.
طبعا شكرا جزيلا لحضرتك انه يعني انت اللي حابب انك تعطي عن الموضوع هذا المهم جدا جدا، وهذا كرم اخلاق منك يعني انك انت اللي عرضت. شكرا جزيلا والله.
لا ابدا والله، ده يعني حضرتك عارف يا دكتور مازن غلاوتك، وعارف انه انا بستمتع بشده بالشغل مع حضرتك
الله
يعني.
يخليك يا رب.
لا الحقيقه انا يعني اغبطك ولا احسدك يعني على بسم الله الله اكبر، على يعني الطاقه الايجابيه وطاقه على العمل. بسم الله الله اكبر. هو بقى انا مكتبي خشب عمال اخبط عليه اهو لكن ربنا يديك الصحة، ودايما تعلم من اللي حواليك يعني.
الله يبارك فيك ويجزيك الخير.
تسلم يا فندم.
هو هو الدق على الخشب يعني مش من عندنا.
لا
احنا
لا مش
نقول
مهم.
بس
انا مش عارف،
ما
انا مش
شاء
عارف
الله لا
هو ده
قوة الا
إيه،
بالله
بس
وبس.
يعني انت عارف في مصر احنا بنمسك الخشب الحقيقة. ده في اغنية، في اغنية اسمها امسكوا الخشب. مش عارف سمعتها
والله
ابدا ولا لا.
والله لا ما سمعتهاش.
اغنيه قديمه جدا مثلا في الستينات ولا حاجه. اظن كان عايده الشاعر او حاجه، يمكن خالد يصلح لي. بس كانت بتقول امسكوا الخشب لحسن ننحسد.
ايوه.
يعني فدي من الموروثات الشعبيه المصريه. انت عارف طبعا ان المصريين جزء كبير من الحاجات اللي بيعملوها ليها اصول
مم.
في التاريخ الفرعوني.
اه
يعني
صح.
من العادات والتقاليد وحاجات كتيره من الاحتفالات،
مهم.
اصولها قديمه جدا ضاربه في القدم يعني. وانا الحقيقه ما يعني بشوف دايما انه اي فرصه للاحتفال او اي فرصه للفرحه، واي نوت. يعني احنا مش لازم نحصر نفسنا في اطار ضيق. اي فرصه ان احنا ننبسط، مفيش اي مشكله. يعني انا حضرتك عارف انا كنت في بغداد قريب من حوالي شهر، وكنت
اه ما شاء الله.
مبهور جدا بازاي الرموز البابليه والاشوريه اتسترا اتسترا لسه موجودة جوه العلامات وجوه الرموز اللي موجودة في المجتمع العراقي. ودي أكتر حاجة قريبة شفتها للمصريين. يعني المصريين عندهم نفس فكرة الرجوع للرموز الفرعوني يعني.
اه نعم صحيح. انا بعد اذن حضرتك حادعو السيد خالد غزالي يكون باناليست برضو معنا.
يا ريت يا ريت.
طبعا ما زال هو جلوكوما، فانا اكيد نستفيد من الحوار.
غير ان خالد دكتور عظيم، فهو كمان رسام مبدع.
ما شاء الله ما شاء الله.
اهلا يا خالد.
اهلا يا طارق، اهلا يا حبيبي.
ازيك؟ وحشني كتير.
خليك، انا حقيقة كنت في مصر برضه في ديسمبر، بس لم يسعفني الفرصه اني اشوفك. الحقيقه كنت مشغول، انت في اسوان اعتقد.
كنت في أسوان. الحقيقة معظم
الله
الوقت كنت في أسوان، بس يعني إن شاء الله ربنا يجمعنا على خير. طبعا
ربنا
يعني
يسهل، امين.
يعني أنا
امين.
مش هقدم الدكتور مازن. طبعا الدكتور مازن غني عن
اه طبعا
التعريف.
الدكتور غالي على
والدكتور
التعريف طبعا.
أخويا الكبير ويعني ورفيق رحلات كثيرة وعزيز عليا جدا جدا جدا. وفي مقام يعني هو الحقيقة إنه صديق شخصي الخالي، فهو
بالظبط.
صديقي وفي مقام خالي كمان، لو يسمح لي إن أنا أقول كده يعني.
اه طبعا
والله
طبعا، مجدي ده
تشرفنا.
حبيبي. على فكره النهارده عيد ميلاده، اتضح شفت في فيسبوك النهارده عيد ميلاد.
طبعا، ما هم ليه ده يعني لازم أنا
بالصدفه
أحتفل.
الموضوع ده. مجدي ده حبيبي من زمان الحقيقه الله.
ربنا
يعني
يخليك.
فعلا من احسن الناس. وعرفت انت يعني اخلاقك طبعا من والدك الله يرحمه،
ربنا يخليك.
ومن خالك يعني يعني لا نثني عليكم يعني.
ربنا يخليك يا رب. انا محظوظ
أيوة.
جدا بان انا اتاثرت بيهم، يعني ان الاثنين
لا الله
خلاني
يخليك، وانا فعلا
كلهم
يعني
الحقيقه كانوا
والله انا دايما
قريبين.
انا بفتخر بيك دايما في كل الاماكن. يعني بقول
ربنا
لهم انا
يخليك.
اعرف واحد اسمه طارق الشعراوي، وده ما شاء الله يعني يعتبر والله فخر للمصريين كلهم والعرب جميعا
يعني
يعني له
طارق
اثر فخر.
شعراوي راجل متشعلق برضا ربنا، لا اكثر ولا
امين.
اقل.
ده اهم شيء، اهم شيء، الحمد لله رب
ربنا
العالمين.
يخليك يا رب يا خالد.
الله يخليك.
ربنا يخليك.
تشرفنا بكم جميعا. يلا نبدأ. بسم
الله
الله
يخليك
الرحمن
يا
الرحيم.
دكتور ماهر، شرفنا بسيادتك كمان.
الله
اهلا
يخليك،
وسهلا.
اهلا وسهلا دكتور خالد والله.
الله يخليك.
نتوكل على الله.
تفضل حضرتك. أول شيء بس أفتتح بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. Hello everybody and welcome to the last but not the least session in the 2021 series of Taming the Monster, the series of glaucoma adventures. And as we say in Arabic, ختامها مسك. We are concluding with Professor Khalid, Professor Tariq Sha'rawi, the very well-known international speaker and expert in glaucoma. He is based in Geneva, in Switzerland, and he has many publications and international speakers in many conferences. You all know him very well, so no need to take more time in the introduction, mashallah. And the stage is yours, Dr. Tariq, please.
Thank you very much. Thank you very much, Dr. Mazen. And I also would like to thank you for the perfect organization of this series of lectures in all specialties of ophthalmology. I am an avid listener to these lectures, whether live or on YouTube. I have actually benefited a lot also from the cornea series. I'm very happy to have Khalid Al-Ghazali, Mr. Khalid Al-Ghazali with us. Khalid Al-Ghazali is a consultant ophthalmologist from the UK, a person with an enormous experience and one of the cleverest and one of the nicest and kindest people that you could ever imagine meeting in your life. So it's a pleasure to be in your company. And this series of lectures is centered actually around trying to pass knowledge in a sense of in a friendly manner. I mean, I do not look at these lectures as a formal series of, very strict, very dry lectures. For me, it's more of a creative process where I would like to pass part of what I think and feel about what I know to the audience, and to listen to their opinions and their ideas and their criticism. So please be as dynamic and as interactive as possible. So this lecture concludes a year-long series of lectures about glaucoma, and it is a very personal point of view, a personal perspective on glaucoma surgery. And this specific lecture, I call it the glaucoma surgery, the art and science. It is very sad if we think of our professions as just mere professions, and if we think of science as a practice without thinking of the creative process behind it. And the creative process behind it of course, belongs to the art school. So for me, surgery in general is part art and part science. Science is logic, is analysis, is communication. Art has a lot to do with intuition, gut feeling, creativity, and emotions. You cannot be, an emotionless surgeon is not a good surgeon, in my opinion. When we speak about glaucoma surgery, I want to remind you that glaucoma surgery has a raw material. The raw material is the conjunctiva. Conjunctiva that is usually treated with a lot of disrespect by ophthalmologists, or at least some ophthalmologists, plays a pivotal role in our practice as glaucoma specialists. If you are working with a good conjunctiva, the chances that you get a good success is much higher than bad conjunctiva. So, as you see, before I operate anybody and before I make a decision about what kind of operation I would do, I would spend time studying, looking at, feeling, touching the conjunctiva to be able to have some degree of understanding about what I'm dealing with. I have been in this business for a long, long time. I've been in this business for, I would say, since the mid-90s. And I've started with trabeculectomies and deep sclerectomies. And with the years, I have used many devices, developed a lot of white hair, lost a lot of hair. And I am in a situation now where I am continuing to learn and continuing to understand and continuing to improve my experience about what we are doing. And one thing that I've learned is that we don't know anything, or we don't know everything, let's put it that way. So it is very important to keep an open mind, to always learn, not to be dogmatic about things, not to be fixated about our opinion, and know that our opinions can change under pressure in some cases, but also it is even better if it changes under the influence of a good observation. So deep sclerectomy, an operation that I still feel is an important tool in my armamentarium, is an operation where we do not open the antechamber, as you can see here. You can see the dissection of a deep sclerectomy. I will take it step by step. We create a flap of about 5 by 5 millimeters. aiming at 1/3 of cornea's thickness, and then we dissect deeper into a second layer that we take out to see or unveil the Schlemm's canal. And to do that, you have to dissect at a 95 or even more percent of the scleral thickness. And once you find the Schlemm's canal, you should remove the inner wall of the Schlemm's canal, and what comes out with it automatically is the endothelial lining or the juxtacanalicular trabeculum. So what is left is what we call the trabeculo-Descemet's membrane. So this is part of the Descemet's membrane and part what is left of the trabeculum, and together they constitute this membrane. And I learned from this operation, as Khalid or Mazen will tell you, that every single step has to be perfected and you have to follow certain rules. One rule in deep sclerectomy is that you have to continuously dissect the deeper flap till you see the choroid. The best surgeon in the world can make a bad calling about where he is in the sclera or where she is in the sclera if we don't see a landmark. The landmark here, as you can see in this video, is the choroid, above which I start to dissect immediately, a few microns above the choroid, I start to dissect to be able to achieve a dissection depth that I know will continue to lead me to a point where I'm going to dissect or bisect the Schlemm's canal into two. So here is the dissection. We advance and make sure that you see the difference between the color here, there, and in the deep bed of dissection, where it is quite darker because there's very little of scleral fibers available on top of the choroid. So you're seeing the choroid shining through what is left of the sclera. And I'm using here a knife that I adore. This is a small crescent knife developed by Greshaber. I have no financial interest in all the tools that you are going to see. And we open into the Schlemm's canal, as you can see here, and slowly dissect laterally and push a little bit to detach the Descemet's membrane from the overlying stroma. So here is the Schlemm's canal, and I move to the next. We can sometimes try to do a blunt dissection of the Descemet's membrane with a blunt spatula, as you can see. And I usually use a number 11 blade with the bevel side up, trying to use the sharp portion to dissect anteriorly and use the blunt portion of the blade to protect the underlying Descemet's membrane, which you can imagine is quite thin and can perforate easily. Now we pull or peel the inner wall of Schlemm's canal with the juxtacanalicular trabeculum. You can use any sort of a good forceps. Here I'm using a forceps that has been designed by André Mermou, my big friend and mentor from the University of Lausanne. And this is basically, you can see here, this material that we took out. This is the inner wall of Schlemm's canal, and you can see it a little bit pigmented. What is left is aqueous coming out, as you can see here, percolating from inside the antechamber. And obviously I am rubbing the Descemet's membrane just to show you how the aqueous is going out and leaving the eye slowly. And that results in a natural barrier that will prevent a loss of the depth of antechamber. Whenever the pressure goes up, you can perforate this membrane. I usually use you can use any gonioscopy lens. I like this lens, which is comes with a very high magnification. This is the CGAL lens from Hagstreit, an energy of 2.5 millijoules, and we create a small holes if the pressure goes up. But don't do that if you decide to do that before 2 months. You need some kind of a resistance to develop, because if you perforate early on, you can result or you can meet a profound hypotony. We do these kinds of operations, and in many cases, we advance with our surgical methods without asking the right questions about if they work or not, and we cannot really, ask every single question. And I cannot do a randomized control trial to compare 4 stitches versus 2 stitches after a deep sclerectomy to close the flap and put 100 patients in each arm. So early on in my career, it was very important for me to take the time to try to understand which questions to ask about the success rate and about the viability of my procedure. For example, when it came to deep sclerectomy, it was very important for me to choose a question, and I was in between looking at goniopuncture and the utility of goniopuncture versus ab externo trabeculectomy. Ab externo trabeculectomy is the step where you remove the inner wall of Schlemm's canal. I chose the goniopuncture, and it was very interesting because it was not very difficult to show that goniopuncture can be an integral part of the procedure and can result in improving significantly the success rate of the procedure. Sometimes you have to go to the laboratory and look at what you're doing. Does it make sense in an animal model or not? For example, the collagen implants that we were using intrasclerally to keep the intrascleral space open, and it was CE marked and FDA approved, but there was not really enough data from a laboratory about the utility. And for that, we went into a series of studies, animal studies. At that time, I was working in Lausanne, and our group published a series of studies using animal models to look at aqueous dynamic and histological findings after using a collagen implant. Basically, I'm trying to demonstrate that clever questions should be asked, and we should not rely just on the fact that a key opinion leader comes to us and says, this operation works. So you should always demand the evidence, and if the evidence is not there, try to find it yourself. One of my big mentors, at least from a theoretical point of view, was the late Edward Said, who in a very interesting book called The Question of Palestine wrote that the greatest enemy of knowledge is not ignorance, but the illusion of knowledge. We should be very aware of the difference between knowledge and the illusion of knowledge. And in terms of knowledge, we know that glaucoma surgery is effective. It provides a good intraocular pressure reduction. It does not depend on compliance, and it provides a very steady reduction of intraocular pressure over 24 hours. And in many places around the world, it is significantly more economical than putting a patient on topical medications for the rest of their lives. In many countries around the world, putting a patient on a topical medication, topical anti-glaucoma medication, is not even an option. In many cases, it's either not there or it is too expensive. Remember that the topical medications cost about $1 per day, and more than 40% of the world live under $2 per day. So which family would put half of its income, of its daily income, for a drop of prostaglandin? Having said so, glaucoma surgery does not come as the holy grail or as the best solution ever, because it comes with a series of complications. And some of these complications are something that we have to ask ourselves about, beware of, and discuss in details with our patients before we guide them towards glaucoma surgery. One of those two of those things that are very important for me, and have been putting a lot of time and energy over the last years, were visual loss and blebdysthesia. So when it comes to what kind of operations that we are doing, this is all what we have now. There's many operations that are available. And sorry. And when we look at these operations, we have to ask ourselves per device, are they safe and are they effective? We cannot just go under the pressure of a big pharma company or a big company that is telling us that this implant or that procedure works without looking at the evidence. And I found early on in my career that glaucoma surgeons are speaking different languages. So that was, as you can see, the guidelines that we published on design and reporting of glaucoma surgical trials. This was a work that I shared with Mark Sherwood, Franz Gren, and about 112 glaucoma surgeons, specialists in ethics. And here is one of the meetings that we had that was during the American Academy, where it was really very difficult to look at all in front of me, all the big names, and you can see George Spaeth and you can see Carlo and Franz Gran, and it was very difficult to reach a consensus. And you can see also some black hair. So I think the World Glaucoma Association guidelines lost me some black hair. Anyway, there are always answers if you look, and if you look deep enough. And it is very important as you align your questions with your own interests and your own research interests to also align them with what is important for our patients. For example, some of our studies have shown that the most that the patient needs from you is to provide him with a safe and comfortable procedure. How many of us, a lot of us think of safety, but how many of us think of comfortability of our patients? And if we look at results with visual acuity, for example, one study, as you can see here, shows that 60% of patients lose 2 or more Snellen lines of best corrected visual acuity after glaucoma procedures. The trabeculectomy versus the tube study shows the same thing. About 1/3 of patients will lose 2 or more lines after 1 year. And in the UK surveys of trabeculectomy, again, visual loss consistently over the years is in the range of 20% of patients drop more than 2 Snellen lines after glaucoma per year, which is catastrophic. So think a lot about comfortability and safety when you're thinking about glaucoma surgery. And think about long-term. For example, putting a tube, it's a foreign body inside the eye. And when we decide to put a tube, we have to understand that it comes with risks like erosion of a tube. This has been very bothersome for me. And many years ago, I developed this technique to try to avoid tube erosion. And that you can see here, we are doing a very big flap. We call this technique the envelope and trench. Envelope, because as you can see, we are going to have a very big side flap. Here it is about 11 millimeters by 7 or 8. We turn it on itself on the side. And then the trench is because we create a deep scleral dissection, as you can see here. And the whole idea of this deep scleral dissection is to replace the amount of sclera that we are taking out with the body of the tube. Thus, the body of the tube will be less prominent on the surface of the eye, and the chances of an erosion would be reduced. And we have produced results to show that this technique is associated with a reduction of erosion. And the reduction of erosion would save you a lot of sleepless nights and a lot of headache. One other thing, if you are putting a tube, try always, if possible, in pseudophakic patients, to put it in the sulcus rather than putting it in the antechamber, in the hope of reduction of the potential for endothelial cells. We have with us one of the best cornea specialists around the world. And Mazen, I'm sorry to tell you, but a lot of what we do as glaucoma surgeons are very nasty to your corneas. And I apologize. Sometimes we have to do that. But in many cases, trust me, I do anything that I can do to protect precious endothelial cells. And I always tell my colleagues, we are not paying for these, or the patients are not paying only in dollars or dirhams or pounds. A lot of them are paying also in endothelial cells, which is a very, very valuable currency. For me, it is more important than gold. You can see here the tube in the sulcus. We're putting it tangential to the visual axis, so as not to disturb the patient, and still to give us some access about the tube. A lot of the glaucoma surgeons look at blebs and think that they are, they have created masterpieces. In French, we call it chef-d'oeuvre. Authentic masterpieces of surgical ingenious, of our hands that are the big creators, which is for me is a joke. Blebs are bad stuff. To get a good bleb is almost an exception, but blebs are an insult over the beautiful topography, the divinely designed topography of the eye. We are actually traumatizing the eye, giving the patients a bleb. And in a previous lecture, I have actually given the audience the opportunity to listen to a bleb, because those blebs have sound. And the glaucoma series on the Sinjab Academy are available on YouTube. You can listen, you can look for the bleb sound, bleb that was speaking to one of our patients. But 15% of blebs are associated with bleb dysesthesia. I think this is a very nice percentage that is probably underreporting the problem. How many of you have seen blebs like that? Blebs related to mitomycin encroaching on the cornea. How many have you seen with blebs that are not leaking, they're actually pouring or oozing? Those are fountains of aqueous coming out of blebs. And just to tell you, I never accept a bad bleb. So you can see here, when a bleb like that is leaking, I know that the patient is moving around carrying a time bomb. The chances of an endophthalmitis or even a blebitis is too high. For those cases, I would intervene. I would do a hydrodissection balloon to be able to know where is the damage. Here I can see that the roof is the issue. So I decide to bluntly and slowly cut the roof of the bleb totally, and then build or construct a new roof. Here it was easy enough, per string stitches with an 8/0 vicryl that are on a round needle, never a spatulated needle. Over the years, I've done a lot of those cases, never up till now, alhamdulillah, I've never actually lost the function of a bleb after revising it. So don't be too afraid to manage your blebs. Try to work it out. Try to make sure that it is a clean and decent bleb. Here is another bleb that I find is, that is, I think, 2 months after the operation. It is, as you can see, becoming encysted, raised. Pressure is going up. The eye is angry. Most surgeons would, send the patient home with a lot of steroids and tell him come back in a week or two. I think here the art plays an important role, because this is not what I do. And I maybe don't have an absolute evidence-based approach to what I do with that, but there's also a gut feeling. If you leave this bleb as nasty as that, there's the chances that it will develop in a good way is very, very low. So what you can see here is I decide to work it out. I decide to, needle it on the slit lamp. I don't see that as difficult. Patient is on topical anesthetic. I go with the needle that is fashioned the way I like it to be fashioned, and I start needling and cutting. And I take my time. Of course, not every single patient will be tolerable, but 90% of my patients will take it with a grain of salt, will withstand this kind of manipulation over the slit lamp, and they do not need to take them all the way to the operating theater. The bleb loses its height, And if you look very carefully, filtration becomes posterior. There has been a name given to this kind of procedures. It's by my very good friend and sort of a mentor, I have to say, Paul Palmberg, who actually called those procedures the Zorro procedures, which actually gives me an opportunity to remind you of that and take a second of rest. So, viva la libertà, don't really be afraid of fighting for freedom and fighting for your blebs. Let's try to focus a little bit in the second part of this procedure on issues that I think is important for our patient: visual loss, loss of comfort, and asking ourselves, have we lost track of patient-oriented outcomes when we are thinking of glaucoma surgery? Are we looking for reduction of pressure at any price, thinking that if we reduce the pressure to lower levels, we should live happily ever after? Or should we be considering other issues? Glaucoma surgeries should be effective, but not while we are increasing the risk. And in many cases, we have to remind ourselves that glaucoma surgeries can be associated with loss of quantitative and qualitative vision, loss of eye comfort, and loss of quality of life. So our job is to basically work this dial to reduce the risk to the lowest levels and increase the efficacy to the highest level possible. With that, we need a lot of experience, we need a lot of creativity. And every single operation that is available in glaucoma surgery now depends on one of 4 strategies: either going into the subconjunctival space, creating a bleb, unfortunately, or as you can see here, working on the conventional outflow, so working on the trabeculum and working on Schlemm's canal, or, one back, or going into the suprachoroidal space, so implanting something between the sclera and the choroid with an access into the antechamber, and finally destroying the ciliary body with whatever you want to use, micropulse, cyclodiode, anything that you like, with varying efficacy to reduce the production of aqueous. This is again all what we have, but again, they're all subconjunctival, or they're all relying on one of the 4 methodologies or strategies that I've mentioned, whether from an inside the eye ab internal or from outside the eye ab external. Comes in the MIGS, minimally invasive glaucoma procedure. I'm a big fan of new surgeries, and I like to look into creative solutions. But I also am modest enough to understand that words and phrases and brands do not really always make sense. We use the term minimally invasive glaucoma surgery as if we really believe that they're minimally invasive. And we forget that when George Barvelt, God rest his soul, actually created the Barvelt implant, he called it a minimally invasive glaucoma procedure. So for me, this is mere marketing. And I am not a man who likes to put brands on things. I am a man who likes to examine everything according to its merits, advantages, and disadvantages. So when we're talking about visual outcomes of MIGS, of the so-called MIGS, there are 2 hopes. One is a less impact on vision, and the other is a faster visual rehabilitation. Is that really true? We don't have good randomized control trials to prove that. So the jury is still out. The photo that you see is from the 1957 Sidney Lumet very important movie, 12 Angry Men. Highly recommended if you have not seen it. And the other promise of some types of MIGS is to be able to do bleb independent procedures. So to get rid of bleb-dependent surgeries, anything that is subconjunctival. And I have to say, when I look at a potential operation that does not have a bleb, I would say في 60 داهية, as we say in Arabic, or good riddance, as we say to many nasty things that we meet in our lives. One procedure that is now available to all of us is the Miniject. Miniject procedure is an implant that we put it in the suprachoroidal space, as you can see here. And those implants are CE marked. They are in studies for FDA approval, not approved yet. But you can see here, we can implant them from an ab internal approach into the suprachoroidal space. The material is very interesting, and there's some hope that things like that the Miniject would be able to provide in the future some sort of drainage without resorting to blebs. But as we are now, we can also rely on what we call the hybrid blebs. Blebs that are basically different from a trabeculectomy or deep sclerectomy. And you can see that the pressor flow, or the micro shunt, also called the macro shunt, and the Zen implant have to be part of a very close competition now about those hybrid blebs. This is the micro shunt, or the pressor flow, and you can see we can thread these implants in the subconjunctival space. They are really fast to do. And by the end of the procedure, we can see aqueous coming out, and they are associated with blebs that are diffuse, not very prominent, and far from the limbus. So potentially they should be more comfortable and even should scar less than after a trabeculectomy or deep sclerectomy. These are our 2-year results. They have been already published, and the results are relatively good. They are still not as good as trabeculectomy, but they are associated with much less problems in terms of complications. Here you can see the micro shunt in terms of trabeculectomy, the difference, and you can see here that the mean intraocular pressure after a trabeculectomy after 1 year was 11, while it was 14 for the micro shunt. Still, I have to say that there is some degree of promise. What I find very interesting is that if they scar, you can always open on this implant. You can see that it has been totally buried in scar tissue, and with very meticulous and slow dissection, you can actually regain function of these tubes. So you see here, the aqueous is actually coming out, and maybe here it is clearer. Once we removed the scar tissue, aqueous is coming out, which is really very nice to see. Put some mitomycin, close the conjunctiva, and you have done a reincarnation or a second life of your implant. But they come with their own prices. This is an implant that came with my patient, and it was already almost coming out, as you can see here, and didn't take me 2 seconds to decide to basically pick it up through the conjunctiva in front of the slit lamp. And in this case, this implant, once removed, left a suprachoroidal cleft, and we had to actually go and fix this suprachoroidal cleft, something that is not really a lot of fun. One message that I would like to share with you today is please be aware that things like peer pressure, that is one of the biases that you can suffer from, should not be an important influence in what kind of procedure that you're using or doing. It's important that you are not influenced by the person in the next city or next street that is doing this or that. You have to go into a real exercise to understand carefully and make a good decision about what kind of procedure you want to choose to offer to your patients. Remember that we also need to make our choices based on health economics, and and what kind of health system we're working in. Finally, wanted to share with you that we always had efficacy, cost, safety, and combined potential for combination with cataract as the drivers for glaucoma surgery. And now things have considerably changed. Visual preservation, comfort level, a short learning curve, being able to combine it with phaco and cost effectiveness, all that, they have to be the new drivers for what kind of procedures that we are using. And above all else, remember the interest of your patient while you're making a choice. And ask yourself always, am I making this choice because I want to change my car? I want to buy a new summer chalet, or am I really doing that because it is the right thing for my patient? Sooner or later, we will rely on robotic procedures in glaucoma surgeries, and you can see here we were toying with the Da Vinci in putting an amniotic membrane on the cornea. I have to say that I was very impressed with the stability of the robot and our ability to even suture using an 8.0. I think this is really going to be the future. So let's not overemphasize our role as surgeons. Know that we have to be modest and that we should not consider ourselves or overrate ourselves, because sooner or later, one way or another, we will be obsolete. Remember that glaucoma surgery is a science and art. And with that, I thank you very much for your attention.
Thank you very much, Professor Tariq. It was really an amazing lecture. I love your way in teaching because it is, first of all, relaxing, as if I'm watching a story, and it is full of information, very simple, direct to the point. Yeah, it's very interesting. The message that you want to say that the good surgeon should have all the options and should be skilled in all options, not only one option, and do it for every patient. So many weapons and to win the battle. All right. I think that this is very similar to what we do in keratoconus patient. And the keratoconus is something which is very, very variable from a patient to another. There is no one keratoconus case which is very similar to another one. Even in the same patient, one eye is very much different from the other eye. So many surgeons, unfortunately, they do, for example, cross-linking for everything. Other surgeons, they do intracorneal rings for everything. So, which is very wrong, actually. And this is the thing that will give the bad reputation of some procedures amongst patients and amongst as well colleagues. This is not because of the procedure is bad, but because it was done in the wrong indication. So I think this is the same message that you want to say, that each case of glaucoma is something unique, something different, that may benefit from a specific type of surgeries. And this is why the glaucoma specialist should have all skills and such, and of course, to be trained and to learn and to be updated and to be humble in order to learn everything new in the future.
Yeah, I think humility is key. The minute a surgeon in whatever type of subspecialty, in whatever subspecialty, loses humility, he opens or she opens the door to many catastrophes. I remember a long time ago that I've seen surgeons that almost stop scrubbing before operations when they're too confident that they think of themselves as sterile, that they don't even carry microbes. So I've seen that they even take something like scrubbing as something optional. You know, this is scary, but it is not unheard of.
Yeah, thank you very much. Dr. Khalid. Dr. Khalid Al-Ghazali, do you like to add something?
Yes, I agree actually with both of you, actually, Dr. Maz and Dr. Tariq. The important thing actually for us as surgeons, in any specialty actually, or any subspecialty, if you have to actually to be able to, so I lost the picture for a minute.
We can hear you, Khalid.
Right. Yes. So yes, I come back again. Yes. Basically, actually, it's very, very important to be able to improve your techniques all the time. I remember actually when I started ophthalmology about almost 40 years ago. At that time, I started, for example, with intercapsular cataract extraction, and that was the holy grail for the cataract at that time, because we have ability to actually dissolve the zonule and able to get the cataract out without any problems. But then the extra capsule came as the routine, and we had to actually teach ourselves how to actually do that properly and go back to what we used to do in the old days of extra capsular, and of course with the implants and so on. And then of course came the phaco after that, and we have to improve, because I remember actually, for example, one of my consultants, he was about to retire in about 4 or 5 years in the early 90s, when we actually started to do phaco as more or less as a routine. And I thought he will never change to do phaco at all, because his techniques with the extra capsule was excellent and he had get excellent results. But I was really surprised that within 6 months, he actually changed to extra capsule, to phaco, although he actually was only going to work for another 4 or 5 years. And again, he actually gets excellent results. But what I'm saying is that it's very, very important not to stick to one technique and say, well, yes, this is actually the word works for me. I'm going to stick to it. I actually don't go to something else, even though that you know that something else is actually much better than what you are doing. I actually did only few deep sclerotomies or non-invasive glaucoma surgery, because I trained to do trabeculectomies for a long, long time. I was doing my trabeculectomies and everything, but I always knew that trabeculectomies doesn't come without its faults. Hypotony is one of the problems, of course, as Ty said, possibility of visual loss, bleb failure, all these kind of things always happen with any very, very good surgeons. And we have to actually improve our techniques. When deep sclerotomy came, and I found it difficult, because I was established consultant by that time, almost consulted for 20 years. And it was very difficult for me actually to learn from someone else. But actually, I learned from my registrars, for example, because I had some registrars who are good glaucoma surgeons who actually trained with some excellent professors or excellent consultants in glaucoma surgery. And they taught them how to do deep sclerotomies in a very good techniques. And I wasn't actually ashamed to ask my registrar, show me how you do this technique, because I want to learn how to do this technique from you. And actually, he actually showing me step by step. You're surprised that how on earth actually, as a consultant for over 20 years, asked him to actually teach something. But I told him, I'm not actually learning from you. I'm actually learning from your consultant, who was my consultant before. But I didn't have the chance to meet him now, but I actually meet him through you. So it's very important to improve your techniques and learn new techniques. As you said, for example, Mazen, that patients with keratoconus, you're not all the same. You don't just treat them all with keratoplasty or all with something like intact and things like that. Each patient has to take it as its merit, and each patient will have some suitable technique for them. And this is important. You have to know as many techniques as possible, and then put the right technique to the right patient.
Yeah, that's true. Thank you very much, Dr. Khalid. We have as well Dr. Hassan Khalid with us. Dr. Hassan is a very expert surgeon in the anterior segment. He is working now in Mughrabi, Mecca, as I think, in Mecca and Jeddah. Is that right, Hassan?
Yes.
He is a glaucoma specialist as well. So Dr. Hassan, please, if you want to add
Dr.
something.
Hassan is a great glaucoma surgeon. I follow his work closely for years, and I've always been impressed with his lectures. And I'm telling you all that, Dr. Hassan, so that you can actually do me a favor and pray for me when you are في المسجد الحرم المكي. Next time, I would ask you for a good prayer while you're there. That would be something that I would be appreciative if you do for me.
Inshallah. Thank you very much, Dr. Tariq, for this is nice presentation and nice talk. Actually, I learned a lot from you. Also, I started doing deep sclerectomy 2 years ago, and I started also do that after reading your book. I have very excellent result. When I started, it was very difficult. The step when you are peeling the
inner wall.
Inner wall of Schlemm canal. It was a big problem, as you need. It's very fine membrane, and this is the step that may you perforate the Descemet membrane and to convert the surgery to trabeculectomy rather than deep sclerectomy. But I mastered this is after about 15 cases. Now I moved to deep sclerectomy in almost of my cases. Also, as you said, that the testing of the conjunctiva is very, very important issue for glaucoma surgeon, because it is a friend of a glaucoma surgeon. You have to test the, as you say, the conjunctiva carefully before on slit-lamp examination, not only under the microscope. You have to test it very well to see the mobility of the conjunctiva, the scarring, the redness, to prepare the patient properly before starting your surgery. Also, looking for the efficacy and safety, as you said, is very important. Also, I will disagree with Dr. Mazen Sinjab regarding to be mastering all the glaucoma surgery. I think it's difficult to mastering all these techniques, but I think if you masters more than 2 or 3 techniques, and you choose the right technique for right patient, is very important. That's it. And thank you very much for this nice talk. Always I learn from you. Thank you very much.
Thank you, Dr. Hassan. Do you mind if I think you spoke about how the inner wall removal is difficult. And as you were speaking about that, I thought of something very simple to show the others, show others how to do it in an easy way. If you think of this paper, I will bring it closer to the camera, as this would be the inner wall, and this area will be the Descemet's membrane. So here we are corneal, and here is where we are coming from our dissection. So if you think of the inner wall as a strip of tissue, as you can see here, what you need to do is, first of all, you have to dry, because if this is not dry, you won't see it. Once you dry, you will see, as you can see here, you will see a limit of this membrane. If I can just point well, between the inner wall and the Descemet, there is this area. What I do is I come with a forceps, any blunt forceps or a capsulexis forceps. I put one side of the forceps here and the other on this strip. So one on the Descemet, so one on the strip, and then I basically, sorry, this is too much. It was a bit of a trauma, but I pull out. So I think you got the idea. We really need to see this strip. Once you see it, so one blade of the forceps on the Descemets and one on the inner wall, so that when you bring them together, you catch it. You catch and then you pull. And that is the easiest way to do it.
This is membrane. It's slightly pigmented. You can see it. while
Not
you
in
add,
every case. Not in every case.
yes,
It is slightly pigmented, and what is very important to know
Yes.
that it is extensible. So it is not a fibrous tissue that does not have elasticity. It's actually elastic. And knowing that it's elastic will make you sure always that you are taking the right piece of tissue and not just any fibrous tissue.
Yeah, I just want to add, Ty, actually, it's very important when you do this technique that you have a very high magnification power.
Absolutely.
It's very, very important, because
Absolutely.
otherwise you might not be able to see exactly where the adjustment may be.
I make it relatively simple, Khaled. I have 3 degrees of magnification that I use on my microscope. I start with a zoom out completely when I take the corneal stitch. And you know this, I think I showed you once this speculum that I use, which is something that I designed years ago. So this is at a complete zoom out. And then I zoom in, do the superficial flap. Then I zoom in once more when I do the deep flap. And at the last, at the end, I zoom in once again when I remove the inner wall of Schlemm's canal. And once I start tying the implants and tying the flap, I zoom out again. So I'm not all the time playing with my feet, but it becomes now, it's sort of like driving, you know, it's like when you do the first gear,
second gear, that's all.
second gear, exactly. It's exactly like that. Of course, manual gear is now something of another age. My son always likes to tease me about these things, but yeah, I mean, surgeons still of our age still do a lot of things manually.
Yeah.
Dr. Mazen, we can't hear you. Sorry.
Yeah. Thank you very much for this nice discussion and nice presentation. I think no questions from the audience so far. Yeah, no questions. So
Can I
that's
just
it.
add something? Actually, when Ty started his talk about the art and science, it reminded me of a talk which I did called The Art of Cataract. And when I started talking about it, people start to look at me in disbelief what I'm talking about. They all thought I'm going to talk about the art of doing a cataract operation, but it wasn't actually. It was a talk about the art and cataract. And I was actually talking about a very famous painter called Monet, who actually had the problem with having developing cataract when he was about 60, 65 years old. And he stopped painting because he couldn't see the colors properly. That was something, I think it was 18, I think he was born in 1805 or something like that. So he actually developed a cataract when it's about 1870 or something. And at that time, of course, the cataract operation was not very, very advanced. And he struggled a lot, actually, but he continued to paint. But what he did, actually, he got the tube of paint and write blue or red in very big writing.
Hello?
He couldn't know exactly what the color is until actually he can read the words. And then he actually did some paintings with the cataracts. And people start to thought, oh my gosh, he's actually having a new kind of school of painting, because all the paintings having this kind of tinge of yellow in it or orange on it. And then eventually someone convinced him to have a cataract operation, which was, of course, was just extra capsular without any implants, have a very thick one of these aphakic lenses. And he actually started to look at his old paintings, and he was really disgusted with the colors which he actually did in these paintings, and he destroyed some of them, which was really quite a shame, because it was lovely paintings. Actually, we still have some of these paintings on the internet. You can look into it. And then he actually, some of his friends told him, you can paint these again. So he actually took his paints and started painting them again with the two colors. And he actually having this kind of like very famous kind of like something called the lilies, which is very, very famous. And he actually managed to continue and finish them before he died.
Yes, the water lilies are quite famous, and the pre-cataract and post-cataract in terms of color.
Yes, and you can see the difference.
Have you had the opportunity, Khaled, to visit his villa near to Paris?
I didn't. No, I didn't.
Because if you go there, you can walk in the area where he was drawing those lilies, and you can see the lilies in his lake. So
it's called,
this is a very nice excursion out of Paris.
Yeah, that's right. I think he has this kind of like this in his garden has something called the Japanese bridge. Or
Yes,
something,
absolutely. You're absolutely right. You're absolutely right.
It's fantastic stories. When you read about it, internet is really very nice.
A big Monet fan like you, and hopefully the COVID time will go fast away, and then you can travel to see it in Paris.
It is on my list actually of places to visit.
Lovely.
Okay, that's fantastic. Science and art today. So thank you very much, Professor Tariq. Thank you, Dr. Khalid, Dr. Hassan, for this beautiful session, and hope to see you all in the new series. And in this particular point, I would like to have the opportunity to thank Dr. Tariq Sha'rawi very much for the support and for inviting a lot of speakers to the new series. And thank you very much, Dr. Tariq, for making this successful.
My absolute pleasure.
Yeah, good night, everybody.
Have a good night.
Inshallah.
Have a good night. Take
Very
care.
much. Thanks.
Assalamu alaikum wa rahmatullahi wa barakatuh. Ma'as salama bi amanillah.
Bye, everybody.